Subscribe to MyStartuptv.
Namaste, I'm Srila Prashankar. In collaboration with MyStartuptv, in our Leadership Talk series, we have our guest today, Dr. Srikala Jwala. Welcome, Dr. Srikala. We are delighted to have you as a guest today. Srikala, we are doing a Leadership Talk series, and you're our 10th guest this evening. We would like to understand your journey right from your college days. What made you take radiology? What made you take up MBBS, and so on and so forth? I will be delighted to ask you more questions on that. Can you please tell us your journey?
Hi, Srilata, and thank you very much for having me on your as your guest on your program. And it's indeed my pleasure. And of course, we have known each other for years now.
20 plus years now.
Yeah, 20 plus years now. So I joined MBBS in the year 1992. And before that, I started my school and my journey through classical dance together when I was 5 years old. Right. So my education and my dance went hand in hand. Sure. So much so that by the time I was 16, 17, I was a regular full Sabha performer, right? Sure. And then I came to these crossroads of, whether choose dance as my career or do medicine. In those days, I come from a service class background. My dad was an officer in Food Corporation of India. So you had a son, he had to be an engineer. And if you had a daughter, she had to be a doctor. So right. That was this typical, middle class prototype. So, I was very passionate about dance and I was pretty good at it. So, and, it's always so exciting standing on the stage and with these beautiful costumes. So I had come to the crossroads in my intermediate, and then I had to choose between being a full-time dancer or being a doctor and also try and continue to pursue my passion, which is dance, Bharatanatyam and Kuchipudi. So my dad said that, arts are always something that give you immense happiness to your soul. So let it remain a passion and let it not be your livelihood. Choose something else as your livelihood so that you can enjoy your dance selflessly, not thinking about, whether you're able to, make money out of it or whether, you're making a name, whether you're getting a platform or anything. You don't have to think about it. You can just dance for the sheer bliss. So I said, yeah, maybe that's right. And then I said, let me give it a try. If I didn't make it in medicine, then I told him that if I'm not getting through medicine, then dance is going to be it. So then I did my BPC in my intermediate, gave my entrance exam, got through, and luckily for me, I got admission in Hyderabad in Gandhi Medical College. And then the journey began. And then because I achieved, I completed my diploma by then. So I didn't have to work really hard on my dance because I was already a performer. So I could focus on my academics and then also pursue my dancing. And then I completed my MBBS. And throughout, I was a regular performer with my Guruji, Dr. K. Umarama. And then I got married in my internship, which was pretty early for today's times. I was just about 23, 24. And then I had to choose a specialty which kept my evenings free to pursue my dance. Wonderful. I didn't want to get into something which would require me to start to sit in a clinic in the evenings. Suppose you're a guide or a pediatrician. There's no way that you can stay home in the evenings. You have to run a clinic to be able to do well in your chosen branch, Okay. So I said, which branch will give me a flexibility where I can work from 9 to 5, come back home and have my evenings to myself.
Why did you choose radiology? And before you answered that, While I understand, normal middle class parents, like you mentioned, is wanting a son to be an engineer, or rather an engineer and a doctor, irrespective of the gender of the children. But didn't you choose arts? Didn't you choose BCom, BSc, because that would have been easier with your dance as your career, as your passion then?
Only see myself either being a doctor or a full-time dancer.
Okay. Those things were very clear, right?
Yeah, it was pretty clear. And then there have been no doctors in my family at all. And we have had certain, issues where we wish there was a doctor from the family.
Sure.
It was always my dad's, ambition that, there should be one doctor in the family. So he said, why don't you try? If you don't make it, then okay, then that is destiny. Whatever is destined is bound to happen. But why don't you give it a serious try? I said, why not?
And you cracked. You said you cracked your MBBS.
I cracked.
What made you take up radiology and not? I understand pediatrician and all is more of a full-time job. But why radiology and why not a dermatology or some other science, some other subsection of medicine?
Yeah, right. So when I was doing my internship, as a house surgeon in Gandhi, I would accompany patients to the Department of Radiology. And we wouldn't be allowed inside. I could only take the patient till there and make him sit. So I would peep in and see what they would do. And that was the time when ultrasonography had come in a big way, and CT scan was just, CT and MRI were just about coming. And then it always fascinated me that we could peep into the human body and see what's happening without having to cut it open. We could
I like the way you said cut
the body
open.
from outside,
right?
And then see what's happening in the liver, what's happening in the kidney, and then it really fascinated me in my house job, because all my friends would say that I would cut out to be a good physician, because of my communication skills or thanks to dance, the way I connect with people. So they said, you have to be sitting in clinic, you are a people's person and stuff. But then it always fascinated me to be able to peep into the human body and see what's happening inside without having to do anything to the patient. That kind of fascinated me. And then radiology was actually the specialty when I had my post-graduation, So radiology
what is radiology? All right. Yeah. What is radiology? For a student who is just wanting to become a doctor, or who's doing her MBBS or his MBBS first year, second year, can you please explain what is radiology? What are the various segments in radiology, and how can one build a career in radiology? So 3 questions for you.
So basically, radiology is a very broad term, and it's actually an oldish term for imaging. Now it's called imageology, because when imaging started, it started with the use of X-rays, right? So we used X-rays and to look, take a radiograph of the chest, radiograph of the broken bones. So because it was using X-rays and radiation, it was called radiology. But as we moved forward, we started using ultrasonic waves, and we started doing ultrasound. We started using MRI, magnetic resonance, and do MRIs. So now it's not just X-rays that we use, but we use so many other energy waves to image the body. So now it's actually imaging. And after imaging, radiology has gone further into interventions where, for somebody who's listening, you would have heard of coronary angiography. What is it? It is putting a catheter, we put a dye into the blood vessels which supply the heart. We image them real time to see where the blocks are. Similarly, you can do that to any vessel in the body, your limbs, your brain, your, upper limbs and body and everything. And then if there are any blocks, we can open them up with stents. If there are aneurysms, if there are balloons in the head, in the brain, we can coil them so that, they don't rupture and the patient doesn't have an emergency. And also, suppose you diagnose a tumor in the liver, you diagnose a tumor in the lung. So we stick in a needle, because now we are in an era where without a biopsy, you cannot treat a patient. So
Right.
it is the radiologist who stick in these needles, get those bits of tissue, submit them for pathologic analysis to get a diagnosis. So basically, we are the doctors who are going to diagnose the patient with their ailments and then give the diagnosis to the treating doctors, so they take it forward from there.
Sure.
You know, I understand there's a lot of clinical science and clinical examination, but in this time and age, because it is evidence-based medicine, everybody depends on the diagnosis made by the radiologist to treat the patients. So
All
in
right.
a nutshell, you are the doctor who's going to tell the patient what is wrong with them and tell the treating doctor that this is what the patient has and this is probably what you got to do with them. That's number one. Number two, with interventional radiology, we are also treating a number of ailments and a number of diseases in our own way. So radiology and imaging, now it encompasses not just diagnosis, but also therapy.
Right.
Yeah.
All right. So when you're talking of the radiology and the explanation, a detailed explanation you gave, can I understand you do radiology for breast cancer. So
Yes.
a radiologist for a breast cancer specialist, can he move into something like for the limbs or for gynecology, etc.?
Yeah, absolutely. See, when I started my career, I was a general radiologist. I was not a subspecialist.
Sure.
I was a general radiologist where I was doing ultrasounds, I was reporting chest x-rays, I was reporting x-rays of every part of the body. I was doing special studies like, we do the barium studies for the gut to know what's happening in the stomach and bowel. I was doing all of that. I was doing ultrasounds of pregnant women. I was doing antenatal, we call them antenatal ultrasound. So I was doing that. I was doing regular ultrasounds. I was looking at CT scans. I was reporting MRI of the brain, spine, the shoulder joint, the prostate. I was doing everything.
Right.
But as we move forward, you got to, because the medicine and each branch of medicine has grown so much in its, the vastness of subject is so much that if you remain a general radiologist for long, it doesn't take you anywhere. Number one. Number two, probably with the kind of developments in every sphere, in every organ, you're not going to be best in doing that. You will be able to report to a certain extent, but you may not be typical of knowledge and competence in every branch that, if you're handling everything, say MRI, CT, you're doing everything. It's like jack of all trades. And
Nicola, your voice is cracking.
So
your voice is cracking. You'll have to come closer.
Yeah, now it's better.
So you'll have to repeat what you just said. I can't.
Yeah. So what I'm saying is, with the development of science and the vastness of knowledge that is available now, and with the advancement of the technology in imaging, there is so much about every organ that is happening, So we are in an era of subspecialization where I do radiology, and then within radiology, we have abdominal imaging, chest imaging, neuroimaging, neurointerventions, interventional radiology, and breast radiology. So it was, as I progressed for about 7 to 8 years, I was a general radiologist. Then an opportunity came in my own organization where they were looking for someone to specialize in breast. And I, being the senior female radiologist in the department, I was asked to go and, train in breast imaging and come back and develop that specialty in my hospital. And then by then I had done quite a bit of general, imaging. So I said, why not? I said, why not? Let me go train and come back and see how I do with my training and how good I am at that, And then I thought, well, I take it forward. And then there's been no looking back, thankfully.
You are associated with Krishna Institute of Medical Sciences, as we know it as KIMS. What are the various aspects that you deal with in breast cancer? What I'm talking about is there are 4 stages, as I know, is in breast cancer. So what is your area of work in terms of all these stages of breast cancer?
So we at KIMS, as you already know, are our advocacy of early breast cancer screening and early pickup of breast cancer has been our campaign and motto right from the time that the unit was established in KIMS, right? So what is early breast cancer and what is breast cancer screening? Early breast cancer is that when the breast cancer, the size of the cancer in the breast is less than a centimeter or a centimeter and a half. Now, why is it important to pick up a cancer that early? When it is 1.5 centimeters, it's barely palpable. So what I'm saying is, we want to pick up cancers even before they become palpable to the surgeon's hand or to the hand of the woman. You know, we always spoke about self-breast examination. I'm talking of something even before something is felt by self-breast examination.
Okay.
You know, there have been a lot of randomized controlled trials done in the Europe and US, where they have found that if you pick up a cancer which is less than 1.5 centimeters, and if the cancer has not spread to the lymph nodes in the armpit, then the 5-year survival rate of this woman is more than 95%. Now, what do I mean by that? I mean, not even 5 years, the 12-year survival rates are between 95 to 98%. Means you're practically talking in terms of cure. So very rarely we use the word cure in the cancer setting. But if this is a screen detected cancer, then I can assure the patient that she is not going to succumb to this cancer.
Sure.
With confidence, you know. So my job entails, it's two things. One is screening for breast cancer. Number two, diagnostic studies, which means that the patient has a complaint, say a lump in the breast, or a nipple discharge, or a simple pain, cyclical pain. You know, every month they have this very severe pain in the breast. So they could come up with any complaint and then we evaluate it.
Sure.
The other limb is woman who's turned 40, and then she just comes to the unit to know if she's well, you know, if everything is fine in the breast. So they just come to do a mammographic screening. So I look at the mammogram, and then if I feel that she would benefit with an ultrasound of the breast, I add that also. If I find something, then I sit them down, counsel them that I've found something which may need further examination in terms of biopsy, where we take out small bits of tissue, send them for diagnosis, and then depending on what the diagnosis is, we tell them what is to be done next, right? Sure. Gone are the days where women felt a lump, they go to the surgeon, nothing is done, the surgeon will remove the lump, send it for testing, and come back and say, okay, it turned out to be a cancer, so you need a second surgery. Okay. So this is now archaic. You know, this is vintage. We do not practice that medicine any longer.
Right.
You know,
I like the way you put it. In the day and age that we live in today, like a lot of young women want to delay their marriage and also delay their childbirth. If a woman has breast cancer, can she nurse a child?
Yes, she can. I mean, you know, depending on what kind of surgery she has chosen. Suppose it's a mastectomy, obviously she cannot, there's no breast there, so but she can comfortably feed from the other breast. And depending on whether it's if she has conserved her breast, and if there is milk let down from that breast, even after radiation, because one must understand that once they choose to do a breast conserving surgery, meaning only the lump and a centimeter of tissue around the lump is removed. And it is always followed by radiation to that breast. So even after that, if there is milk production from that side of the breast, she can comfortably nurse the breast. Right. There's nothing stopping them from nursing the baby. They can very well nurse the baby.
Right. My second follow-up question to the same question is, so she's had a tumor, she's gone through a surgery, she's not yet gone through chemo or radiation. Can she nurse the child?
She can, very well. She can. There's no relation to cancer, and once the cancer is removed and she's well, she can nurse the child.
She can
and
nurse
it's
the
not
child.
like the cancer cells are going to get into the
baby.
milk, and these are all
Right.
just misconceptions that people have. But
Right.
as long as there is production, and because see, some ducts are going to get injured while the surgery is done. So if the other ducts which are intact are still producing milk, very well she can nurse the child.
All right. I mean, I'm sure these questions may be simple for you, but I would like to answer it
Yes,
on behalf of all the
These
audience.
are a lot of myths and misconceptions that women have, and this adds to that fear, fear that they have. Yeah, so it's always nice to dispel these myths. Yeah.
Doctor, you have been in radiology for many, many years now. You must have seen patients like my sister who just breeze through it. Patients who are, anxiety driven, very, very scared of even a needle. So how do you counsel them? What are the various things that a patient should understand before she even approaches you?
See, frankly, fear gets them nowhere. I have these women who feel a lump when it is probably just about 2.5 centimeters.
Right.
The fear of biopsy and the fear that
needle cell
might turn out to be a cancer. Forget about the needle. The fear that, if I go and present myself to a doctor, and if this turns out to be a cancer, so they're going to remove my breast, my hair is going to fall away. So thinking of all of this, they don't even step out of their house to even get themselves examined in the first place.
Right.
For all you know, it could be an infected cyst. It could just be a fibroadenoma, a non-cancerous lump. They just sit on that. Now, unfortunately, what happens is, as you said, there are 4 stages in breast cancer. So once the cancer jumps from one stage to the other, the prognosis meaning the life that they have after treatment with cancer, the disease-free life, the recurrence-free life, or the longevity they have after cancer therapy keeps coming down. Right. If I say screen-detected cancer, 95 to 98% 12-year survival rate, I'm not going to talk in 90% when I'm talking about a 3-centimeter cancer. I'm not going to talk about survival rates in stage 3 or stage 4 disease. I'm not even going to talk about 12-year survival rates. We are only talking about 5-year survival rates, right? So the fear is going to get them nowhere,
Sure.
So, but unfortunately, yes, you'll be surprised. We think education equips and empowers these women. No, education has nothing to do with this. It is the way they are, the way they are made, and also
society
the
plays
family, family that they are surrounded.
Right.
The family plays an enormous role in all of this. Talking to them, convincing them, the children, you're talking about a 45, 48-year-old, probably she has a 20, 22-year-old daughter or a son. So, having that relationship where she can openly talk about what she has, and for them to pay attention, pay heed to what she's saying, bring them to a hospital. And then, it requires a lot of talking and convincing, but that's what we are here for,
Right.
So we tell them that, for all it may not be anything. Just give me that half an hour of yours and we will tell you what's wrong with you,
Sure.
So yeah, we have to convince them to do what is right for their own good. Yeah.
So even the educated urban society women don't understand what is breast cancer or don't understand how to examine themselves. Point one is, what do you suggest for them? Point two is, what if I know it and I'm like, damn scared of needles. I don't want to, I understand cancer means death. So I don't want to go and approach a doctor. So how do you address my two questions?
See, number one, knowing what is normal for you is very important. Normal meaning, how does your breast feel before your cycle and after your cycle? Because you must understand, breast is an extremely dynamic organ. Like, see, we understand that every time a woman menstruates, and it's a cycle of ovulation, and then 15 days later she has her period, and she knows, ovaries have ovulated and the uterus lining is shedding away. But what we don't understand is, along with all of this, the breast is also undergoing its own changes, because the breast, every cycle is preparing for pregnancy. The breast is preparing itself to produce milk. Those hormonal estrogen, progesterone, all these are having an effect on the breast also. So it's important to know what is normal for you. How does your breast feel before the period and after the period? Now is the era of breast cancer screening. So any woman who is over the age of 40, we advise that they go for a mammographic screening once a year until they're about 60. And after 60, we would call them biennially, once in 2 years, right? With or without ultrasound. That depends again on how your breast is composed. So we add an ultrasound. Now, below 40, my advice would be to do a self-breast examination every month while you're taking a shower. There are umpteen number of videos on YouTube which explain to you how you have to examine your breast and know what is normal for you and what is a normal variation that happens to your breast with your menstrual cycle. Because unfortunately, under 40, if you do not have a family history of breast cancer, we do not offer mammography or any form of breast cancer screening. But having said that, in our country, more and more we are seeing women between the age of 30 and 40 coming with breast cancers. So I really can't say that, you don't have to do anything. Don't do screening. Don't do self-breast examination because it is no longer scientific. We have to offer them something, after they are 30. So I believe that between 30 and 40, definitely a self-breast examination would pick up a lump, if not screen detected, at least when it is less than 2 centimeters, let's say. Right? Even then, it's a T1 tumor. It is still a T1. Anything below 2 centimeters is a tumor which is stage 1. And most likely it has not spread to the lymph nodes. Right?
So that was my question. Next question. You rightly mentioned, people within the women between 30 and 40 years. Today, we find young women, late 20s or early 30s, having breast cancer. What are the reasons? Is it just lifestyle or is it food?
I strongly believe if you take out the genetic predisposition, okay, there is a subset, about 10% of cancers are genetic. One must understand that if you have a family history of breast cancer or ovarian cancer, you may be predisposed to have a breast or an ovarian cancer, or rarely a colonic cancer. All right. So family history meaning grandmother on both sides, paternal, maternal, aunts, maternal aunts, paternal aunts, and your own mother and sisters. So this forms the family history of breast cancer. Right now, if we take out that subset of people who have family history of breast cancer, the rest are all these sporadic cases of breast cancer for whom we really don't have an explanation in this time as I speak. But we surmise that it has got to do with it's either from the air, the Panchabhuta, as I would say. I always say, what is body made of? After all, it's made of these 5 elements. It's the air, the water, the food. Indirectly, the food comes from the soil. So it has to come from any one of these. And
Again,
of course,
the soil is filled with chemicals and what
chemicals,
pesticides,
absolutely,
etc.
pesticides. So plastics, are being blamed in a very big way for many cancers, especially the female cancers,
Right.
because these are all estrogen dependent, and there's a theory that these plastic molecules mimic estrogen, and the body senses it as exogenous estrogen and reacts to it as if it would react to it.
If my family member, my sister, my mother, my maternal cousins, maternal grandparents, grandmothers specifically, have cancer, am I a high risk patient?
Certainly. So, how we stratify risk is that we look at first degree and second degree relatives. First degree meaning mother and sister, your immediate blood relations, your mom and your sisters, older or younger sisters. And second degree would be your mom's sister or your grandmother. Third degree would be your cousins, your aunt's daughter or your masi's daughter, your bua's daughter. That would be third degree. So we say that if you have a single first degree relative who was diagnosed with breast cancer under the age of 40, then you're straight away a high risk.
Sure.
Then if you have two second degree relatives under the age of 50, then you're a high risk.
Okay.
Now, you can ask me, so what? Why is this important?
Right.
This is important because I'm not going to be recommending you the same set of tests in the same interval as I would recommend to a person in the general population. Because when we say high risk, the chance of this person getting a breast cancer is close to 20 to 25%. Lifetime risk is 20 to 25%. And when we say average risk, we are talking about 10 to 12%.
Okay.
So you carry twice the risk of breast cancer than the general population. So the kind of tests I'm going to do on you are going to be different. And the time intervals are also going to be much shorter. Right?
What do you mean by time intervals being shorter?
See, for the general population, as I said, some countries recommend breast cancer screening once in a year after the age of 50. Some countries recommend once in 2 years, and some others recommend once in 3 years. Depending on which country you live. But unfortunately, in India, we do not have population-based breast cancer screening programs because the scientific explanation for that is that breast cancer incidence has not attained such proportions that it can be added in a regular screening program.
Okay.
Right? So, but then, as doctors and specialists, we see so much happening around us that we don't think we are very far away from that day when, breast cancer is going to take, is going to take epidemic proportions, right? So yeah, that is scary. That is scary, really, believe me. So as on today, what we recommend is an annual mammogram for the general population, an annual mammogram starting the age of 40, at least till 60, and then you can come once in 2 years. Okay. But if you qualify as a high risk for breast cancer, then the recommendations as we speak today are that I see you every 6 months.
Got it.
So I do a mammogram and an MRI of the breast at 6 monthly intervals.
Okay.
Right? So I'm seeing you every 6 months. So if you see me in January, for example, I do a mammogram. And then I bring you back in July for an MRI of the breast.
Okay. And
then take you, do a mammogram in the following January. So I see you every 6 months so that I do not miss cancer that has started, assuming that, today you're well and tomorrow something is started. 6 months is not too far away to get a control on the disease. Okay. So that's where we are today.
What is the difference between ultrasound, MRI, and CT scan?
Okay. Ultrasound is where we use the sound waves. Technically, we use the ultrasonic waves in the frequency of about 3.5 to 15 megahertz, depending on which organ you're interrogating or which organ we are examining. All right. So in ultrasound, we have a transducer, a probe. You must have gone through that ultrasound, right? There is this funny little thing that we rub on
like a mouse
with a gel. Yeah, very, very similar to a mouse. So that emanates ultrasonic waves which hit the organ and then get reflected. So for abdomen and deeper structures, we use higher frequency, obviously, because frequency is indirectly proportional to penetration. So if we want more penetration, we want lesser frequency.
Right.
Now, if I'm examining your thyroid gland, or I'm doing an ultrasound for, these IT guys have this carpal tunnel all the time,
Me here.
I know, that's why I'm saying that. So you guys are on the laptops and mouse. So if I have to see what's happening in your carpal tunnel, then I don't want too much penetration, right? So I'm going to use high frequency for superficial structures and lower frequency for deeper structures.
Okay.
So
in fact, I have a carpal tunnel syndrome.
So you need an ultrasound. So ultrasound is no radiation. So as I said, we use ultrasound, ultrasonic waves, which do not carry any radiation hazard with that. So we can perform them. It's more easily available. Of course, it is operator dependent because it depends on how much knowledge I have, how much competence I have in interpreting what I'm seeing on my monitor. Right? And then whether I have actually looked at that organ that carefully or not. It is not automatic. It is operator dependent. It depends on the skill of the person who is performing. Now, the next is CT scan. CT scan is again an X-ray based investigation. We used X-rays to do our chest X-ray, a simple X-ray, or a broken bone or a back, a painful back, you do an X-ray or radiogram. So we use the same X-rays, but here what we do is we take cross-section of the abdomen or the brain, we slice it slice by slice and get sections of the body and we interpret those images. So these are all black and white and shades of gray.
Sure. When you what Srikala mentioned was slice is not cutting slices into like beans or bendi, but slicing in terms of the imaging.
Images. I'm getting a slice by slice image of the organs in the body, right from the skin to skin. So I'm able to see the liver. It depends on how much thickness I have in my setting. Depending on the indications, it's too technical, but that is what we do. We get a slice by slice image of the chest, the abdomen, the brain, the legs, the thighs, the pelvis, all of that. But this involves radiation. So, CT scan became extremely, a household discussion thanks to COVID. Everybody knows CT chest, that is the investigation to diagnose COVID.
Sure.
So we all got a lot of radiation thanks to COVID. But yes, if there is one investigation that one has to be little wary about in terms of radiation dose, it is CT scan.
All right. Can a lady get breast cancer post-menopause?
Absolutely. Absolutely. Breast cancer, if we are not talking about the young cancers, is a disease of the peri and post-menopausal women. Theoretically, I would say, because I've seen so many young now, I don't want to scare people who are watching me, but then, yes, we are looking at a different disease. The disease is evolving into a different one now, but historically and in general population, it is a disease of the peri and the post-menopausal women.
Menopause, yeah. What Srikala is definitely not scaring, but more educative to the audience, to the young audience out there. Young professionals, both students and young professionals who are not aware of breast cancer. She's just explaining in detail and not scaring anybody.
Yeah. See, awareness and knowledge is power.
Absolutely,
No
absolutely.
matter
Yes.
what your age, you could be 22, 25, 28, 30, 30.
Or even 58.
Anything, you're a woman, you have breasts, you're at risk,
Right.
right? So anytime you feel something different, it's always wise to
Please
go
go to a doctor.
examined, get evaluated. That's all that I'm saying.
Sure. As a radiologist, as a doctor, what are the three very exciting things that you have faced in your career? And what are three challenges that you have faced?
Three exciting is...
Exciting, or, that adrenaline jump.
When you're doing your post-graduation and you're training in radiology, of course, in your house job, you do deliver babies in the labor room posting, and you see the babies, the newborn babies. I mean, it's amazing to, as a 23-year-old to hold newborn which you have delivered in the labor room. I mean, that's amazing. But to add to that, I ended up doing radiology where I tell the woman that she's pregnant, and I see the baby grow from the time it was conceived to probably a day before it is delivered. And there are times when I've seen the baby, I've scanned the baby a day after it's delivered. So I've seen the entire journey from the time that it was conceived, and it's looking at you in flesh and blood. The baby is staring at you. I mean, I cannot explain that, that feeling that it gives me. It's extremely very gratifying, and you feel so blessed. You feel so blessed.
But as radiologist, what are the three exciting things that you went through?
Yeah, so when I tell a woman, somebody longing to have a baby, and I tell them that you're pregnant, I see the joy in their face, and when they deliver the baby, they come to you and say, "Doctor, this is my baby." Oh, that makes me amazed,
True.
And the other one was when I first diagnosed the first screen detected breast cancer. I remember the lady's name. I cannot reveal for the reasons of anonymity. She was a 50-year-old unmarried lady who was staying with her brother and was working for the national, the NFC. So as a part of our screening, when we started off, we had this bus which was going to all these organizations, a mobile van where we were getting women to do breast cancer screening. So she was 50-year-old and she came, and I read her mammograms a couple of days after it was done. And I picked up this little 5 millimeter area of distortion. So we sent a message to the NFC saying such and such a woman who came for her screening needs an additional test. So she came to us. She stays with her brother and family. And I did the biopsy. And imagine doing a biopsy of a 4 millimeter tumor. It's as good as it can get, and tough. That was my first case after my training, and the gap of size. It's really tiny. And there was a gap of 6 months between my training and me starting to do breast cancer screening. So I was not sure of my skills, and I did get the right tissue. And my pathologist called me and said, "See, you must understand that unless I pick this up and I biopsy it, my pathologist is not going to get a chance to see such a small early cancer."
Got it.
We are as good as what we see and we get as a clinical material. So my pathologist called and said, "Jwala, I have not seen a cancer as early as this in ages." So she confirmed that it was an early cancer. This was in 2007, December. And believe me, she was in my office 4 months ago, about 6 months ago. And she's doing absolutely fine. She's now 2007 to 2023, 16 years. She's 66, 67-year-old, absolutely fine. And then more, that, God has given me this opportunity to to save a life. You
Hmm.
know, I'm so fortunate that, you know, I have this opportunity to make a difference in a woman's life. It's
Sure.
absolutely thrilling. And
What are
number
the
three
challenges you had?
is, sorry?
What are the challenges you went through?
Challenges are difficult patients.
Hmm.
Are, you know, the minute you say, I see something, they just break down, and it's so difficult for them to, it's a shock.
Process.
You know, somebody just walks in thinking, you know, she knows everything is going well in her life. She has a beautiful family, children are doing well, husband is extremely supportive. She just walks into the clinic assuming everything is fine. And here I am telling her across the table, the dear lady, this is what is wrong with you. This is a cancer, unfortunately. Believe me, it's not easy.
True.
It's not easy because I'm a woman. I have a family. I have a young family, and you know how important a woman is to the household. You know, everything revolves around.
Yeah, she's
Lady,
the
because
fulcrum.
she holds everything together, and to see them crumble and just, you know, be devastated in front of you is not easy at all. It is extremely challenging. No matter how many hundreds or thousands of women I would have spoken to, every day it is different. And
True.
for me, she is an N number, but for her, it's only me. And
No,
I
for
have
you,
to keep,
for you also, she's a new case. She's a new person to deal with and emotions to deal with.
some people say, doctor, oh yeah, you see so many every day. For you, it's nothing. No, it's not like that. It's not like that, because I understand that I'm the only one for her. For me, she may be the fifth case of the day, but I understand that I am the only one for her as on that day in that moment. So I have to keep giving myself this, this morale, the boost. You know, we also crumble. We also feel bad. You know, I have to break this news to a 32-year-old lady with 2 little children. I mean, to tell her that she has a cancer, and believe me, young cancers don't do well. I know everything, but then I have to put up this brave face, and I have to be that pillar of support in that moment to her. I cannot be emotional. I cannot be sympathetic. I have to be extremely stoic, put this across to her, but at the same time be empathetic to her.
Very
Give her
true.
all that support.
Yeah, very well mentioned that you said empathy, because you cannot be rude, you cannot be stern, you cannot get angry. These are some elements which I think a doctor plays a vital role in dealing with emotions for her own self and for the patients. You're not only dealing with patients, you're dealing with patients' family, and they can get hyper, they can get angry. So how do you deal with the patient's family?
You know,
More than anger and angst or depression, they get very hyper. So
you have to just calm them down, keep talking, and then, you know, that is what, you know, that is where all the other things that we do, that we need to do as doctors come in. You know, even as doctors, because you know, I don't know if I can say this, but this is a lot of negativity. You know, if you're telling when she has a cancer, she's sobbing, she's crying, the husband breaks down, the children are devastated. So it's not just the patient. When it's cancer, it is the entire family. So you are breaking the bad news. So for me to gather that composure, that strength, I have to train myself to do that. I have to work on myself. You know, each one of us has a coping mechanism. For someone, it may be meditation. For someone, it can be fitness, running. For someone, it could be nature walks. For someone, it could be music. But we need to look at something beyond the physical to be able to gather that kind of balance and composure, to be able to handle these patients at the same way at 9 a.m. in the morning to 4 o'clock in the evening. You know, you must remember that as doctors, we are human. We also have a family to go back to. I cannot allow this to affect my balance of mind when I come back to a family which is waiting to, share their day, how their day unfolded. So I got to have that patience, not just with my patients, but also with family. So for me personally, it is music and meditation, which I believe gives me that strength and the love of the work that I have. I just love what I do. I just love what I do, and I believe this is the purpose of my life. I keep reminding it. Yes, we have our good days, we have our bad days, we have very difficult patients. But then, we just got to sit down, calm down, give ourselves that 10 to 15 minutes, take a deep breath, go back.
Go back and attack the next day, right?
Yeah.
Like Dr. Srikala just mentioned, it is what is very, very visible in her talk as she's not just a doctor who likes her job, it's the passion that drives her. It's very visible on her face and eyes. That's passion is what drives her every day, irrespective of the disease that she's going through, or she's treating patients. I'm sorry, I'm not going through, but treating patients and their families that they deal with. It is the passion, like she very rightly said, she deals with a zillion amounts of emotions of her own self, dealing with patients, dealing with families, because it's not easy to tell a patient who's just walked into her clinic saying, hey, you got cancer. And nobody in cancer today, till date, despite technology advancement, is still a very forbidden word. Srikala, lovely talking to you. My next question to you is, what do you suggest, advise the young medical students who want to take up medicine, become doctors, not necessarily radiology, but become doctors as neuroscience, gynecology, etc. What is the advice that you would give young doctors?
As I said, and as you said, passion is the key word. And you must remember, you should not, studying medicine entails studying for at least 6 to 9 years. 6 plus 3 plus 3, about 9 to 12 years before you come out as a specialist or a subspecialist, at least 12 years. So you're giving 12 years of your prime life to this subject. So obviously I need not say that the kind of passion you should have, that, it has to be immense, and then you should be willing to work hard. And you have to have compassion, because here these are people. These are people in flesh and blood. These are not computers. These are not brick and mortar. These are not wires, right? These are not cash. These are not papers. These are people in flesh and blood with emotions, sentiments, and you cannot deal with them as a job,
Also, you cannot deal with the same with different patients in the same manner.
The same way,
You have to deal with the Srikala differently. You have to deal with
Absolutely, there is no just one right way. There's a certain way I would talk to somebody. I can't repeat the same thing to another lady because she speaks to me from a different plane. So I got to get myself to her plane and then talk to her in a frequency that would match her, the kind of person that she is. And then all this comes provided you have the passion for it. Identify what you like. Remember, this is what you're going to practice for the rest of your life. So you better like what you're doing. Don't do it because it is fashionable to be a doctor, or there's family pressure, or you think you can earn a lot of money. Believe me, if you think there is a lot of money in medicine, I'm sorry, no. There's not a lot of money in medicine. There are 100 better ways of making money, and much earlier than you would make money in medicine, because by the time you just qualify and come out, you're going to be 28, 30. And then that's when you have just started. And you look at your engineering colleagues who are, who have a 5-digit annual salary, you're going to be in depression, So this is not a profession that you should come for if money is your aim. There are 100 different ways of making money. Yes, you will make money also, but primarily understand that you're investing 12 years of your life. So you got to love it and enjoy it and have a passion for this and have a love for humanity.
Money is not just the factor. Money is one of the probably the factors.
One of the things. Money will come. Money will come. Medicine as a career assures you of a decent living. It doesn't assure you richness.
Luxury, yeah.
Understand? Luxury. You will have a good life. You will have a lot of respect in the society. You are, as doctors, when everybody knows that we do derive, but then that comes with a lot of hard work, passion, and commitment.
And compassion, like you rightly said.
You can't do it like any other job.
Right. And for all the weak hearts or the girls or boys who run away from medicine, please run away from injections. Please don't take medicine. Yeah. Last couple of questions. How do you manage to have work-life balance? You also mentioned, and I know you personally, that you are a classical Kuchipudi dancer. My first question to you is, do you still continue to perform? Second is, how do you manage to have a work-life balance? Work-life balance, not just work and home, but work and a second career in terms of Kuchipudi dance.
Yeah. So luckily for me, as I said, by the time I came to my 12th standard, I was, I was a pretty decent performer. So, I was through my basics and I was performing regularly. So through my medicine, I continued my art. I never bunked my dance classes, citing difficult exams and stuff like that. I know my mother, I should thank my mother for that, because, it might sound very cliche, but time management is the key.
Okay.
I always I tell my children also that this moment, as I'm talking to you, I look at it this way. This is time away from home, from family, from dance, from my work, right? So the value that I attach to this moment in my hand is all that I'm depriving myself, which I enjoy much, much more. So when I think of it that way, this moment becomes extremely valuable to me. Right. And I give my 150% to this moment in hand. This is something that my mother drove into my head, that the moment in hand, once gone, is gone forever. So make the best of it. I mean, you'll be surprised. I performed through my board exams in my 10th. There was this gap of 3-4 days between exams. And I had this very prestigious performance where I think R. Venkatraman was the president of India. And I was playing a very key role in a ballet, which my guru had choreographed. And she wanted me to perform. In between my exams was the day of the performance.
Sure.
She told my mother, and she said, why are you even asking me about that? You should just go dance and come. What were you doing the entire year if you cannot pass an exam, if you didn't study one day before the examination? That's so sad. And I was like, okay. I went ahead and performed. So it does take, but then, if you love doing what you're doing, you wouldn't do it any other way.
Absolutely. Do you still perform?
Yes, I do. Not like like your sister, but then yes, at least 5 to 6 shows a year. And I try and teach a few students in the weekends because I took over as a director of my dance teachers academy after she left. So I have a few students. So I run a dance school. So I take dance classes twice a week, and I keep it alive because that's where I completely unwind.
Absolutely.
Is that's
spoken like my sister has. I completely resonate with what Srikala mentioned. I come from a family of art. My sisters have been Bharatanatyam dancers. Sorry, I repeat. Varshini, you'll have to edit that. So my sisters are Bharatanatyam artists, very well-known, renowned artists, and Ananda Shankar, has had her corporate as IRTS officer and a dancer, and she's managed both simultaneously. In my own way, I am a HR professional and do podcasts, write poetry, etc. So the context of not having time doesn't come into the picture at all. Yes, like she rightly said, you'll have to manage time, you have to allocate time, and you can do 10,000 things at the same time. My last question to you, or second last question to you, is what do you wish to do in future as a doctor and in terms of your Kuchipudi career? I would like to believe it's a career.
I would, I do a lot of diagnostic work, but in the next phase of my career, I would like to do more work on the field. Reach out to these women at the taluk level, at the village level, maybe, train people to go and, teach them the importance of breast cancer screening or self-breast examination in case they don't have access for mammography. Try and see if we can kind of, try and get a mobile van for breast cancer screening in the, underprivileged women in the villages and in and around Hyderabad to start with. So I want to take the next phase of my career into, to be more socially relevant, not just sit in the hospital. Of course, that is always there, but because that's where you are actually looking at patients with breast cancer, diagnosing them, that is also important. And
but you want to reach out to more people.
Advocate, take the breast cancer screening advocacy forward, give a thrust to this campaign, educate women, both rural and urban. I don't believe urban women are any wiser. They are as foolish. I'm sorry, but I know because I've seen them. You sometimes wonder, they're so educated, and how dumb can they be? When it comes to their health, their body, you'll be surprised, how dumb they can be sometimes. Probably stemming from a deep fear inside them, probably. That's what I think, and just forgive them for that. But then try and educate the young women, because if I'm talking to a 22, 23-year-old, I'm educating her. At the same time, she is going home and looking after her mother, her sister, her grandmother. So I want to empower these young girls, especially in corporate offices, in IT offices. We do that, during the Women's Day celebrations and
but it should be more often.
Breast Cancer Awareness Month. So I want to reach out to these young girls, educate them about breast cancer, and then also educate them that cancer now is not synonymous to death. There's so much happening in cancer therapy that you don't have to think of succumbing to the disease. There's so much we can do. Yes, it do go through a bit of pain and a little bit of, you have to attain that. But then after that year or two, you're completely well. You have an entire life ahead of you.
Absolutely.
So cancer now is not synonymous to death any longer. So one has to get that myth out of their head. So I want to work more in the public and, have more work relevant, socially. So that's where I see myself going in terms of being a doctor, and especially how breast imaging happened to me is a story by itself. So I believe I'm here with a purpose. So I think that's where I think I should be going, and then He'll take me there. And then as regards to Kuchipudi, I'm teaching now, and then I'd like to probably train students academically, maybe prepare them for examinations, prepare them to take Kuchipudi as a career path, train them academically in Kuchipudi, maybe for a BA or an MA dance and PhD in dance, events that kind of interest in them to take up art as a career, if I can manage that. And then, of course, in breast imaging too, I want to train more and more radiologists in breast radiology, because among all subspecialties in radiology, breast imaging is quite nascent, quite young, and not many radiologists understand the importance and its potential for the future. So I want to train more and more women radiologists or men, male radiologists who want to take up breast imaging.
Sure.
I want to train more of them and bring them into this society for the greater good of women in this country.
I think from my end, I would love to introduce you and invite you to various corporate organizations where you can come and educate the young women, both men and women, because men can also go and educate their mother, sister, brother, whatever, mother, sister, grandmother.
Grandmother,
it's very important. I will definitely take it up and introduce you to various corporate organizations. Depending on your time, I would love to have you come and address them. If I don't do it, please ping me and say, hey, please introduce me. I would love to do it. So it was wonderful talking to you, Srikala. Thank you so much for being our guest today. You have really opened up many areas where people are kind of having a negative image on breast cancer, the seriousness or the disease per se. And I think you have also opened up the fact that it can be very, very positive. So thank you so much. It was wonderful talking to you. Thank you so much.
Yeah, my pleasure. Thank you so much for having me on your show. Thank you.
Srikala, can you please let us know what are the various awards that you won in your entire career so far?
Yeah, so I'm a recipient of Annamacharya Scholarship, and then I have been an invited performer at the Khajuraho Dance Festival, and I've had a title of Nritya Chudamani from Pushpagiri Swamiji from the Mutt.
And your awards as a doctor?
Doctor, my paper was adjudged the best paper in our national conference as a postgraduate. And then I've presented a lot of scientific work in our prestigious, our national journal, which is the Indian Journal of Radiology and Imaging. And then I'm a very avid speaker in a lot of our CMEs, the continuing medical education. And then I've held a very high position in our breast imaging society. And some of my papers and my work have won gold medals. So, wow. Yeah.
Srikala, it was wonderful talking to you. You have explained in detail what is breast cancer. You have ensured that people are not going by the myths. You have explained or opened up various ideas, various thoughts in young women, and they should not look at breast cancer in the negative manner. And there is huge amount of potential of life after cancer. It was wonderful talking to you. Thank you for being a guest. Like I mentioned, you are our 10th guest. It was wonderful talking to you. Thank you so much.
Thank you for the opportunity. Pleasure is all mine. Thank you so much.
Thank you.
To stay informed about the startup ecosystem, subscribe to MyStartup TV.
Basically, what we're doing at 63 Sats is we're in the process of becoming India's largest cybersecurity company. The way we do it is, of course, providing our cutting edge services, solutions, and products in cybersecurity. We are sourcing and bringing the best, most innovative cybersecurity products from Israel to the Indian market. About myself, I was born and raised in Israel, worked in various roles in cybersecurity for the Israeli government for the past almost 20 years. And therefore, I'm very well versed with the Israeli tech and cyber community. And I'm trying to do my best in bringing this expertise to the Indian market. Thank you very much.
To stay informed about the startup ecosystem, subscribe to My Startup TV.
To partner with Associam to increase awareness in Hyderabad regarding cybersecurity, the challenges and opportunities. We had a very large panel. We also had Shika Goel, Mayam, who heads the cybersecurity initiative by Cyber Police Hyderabad. And 63 SATS is also here to taking up the challenges and opportunities in cybersecurity. 63 Moons has started this new venture in cybersecurity, and we are taking the country by storm. We have a product for the citizens, we have a product for the enterprise, and the Cyberdome for large critical infrastructures of our country. We come here with a unique opportunity also of discussing franchisee model, that we are the first in the country to do the franchising.
To stay informed about the startup ecosystem, subscribe to My Startup TV.
Hi, I'm MV Pandurangarao from the Department of Computer Science and Engineering, IIT Hyderabad, and this has been a very productive conference on cybersecurity challenges and opportunities. There have been a lot of viewpoints from the industry, from the government, as well as from the academia, which I represent. It has been a very fruitful experience, and I hope all the delegates will gain a lot of information and knowledge from this conference. Thank you.
To stay informed about the startup ecosystem, subscribe to My Startup TV.
A person, who needs no introduction, but again, please allow me to introduce Dr. Jaydeep Ganguly, not a physician because we have a lot of other doctors as well today. We are going to cover 50 plus years of work in 20 minutes. So we'll be flying by decades and minutes actually. But I want to leave with you, there's so much of hype and talk about AI. Some of it is good, some of it is not so good, that I wanted to take the opportunity to walk you through from the very early days, how it all started, because I happened to be there at MIT with when all of these things were happening with Macy and Papert and everybody else. And since then, what we are doing today is very, very different. And my first observation would be that I would urge you to consider that we don't know what intelligence is. So before we say something is artificial, we need to know what is the real stuff. If you talk to neurologists, and I am not a physician, I have deep interest in these subjects, so I study the brain. As time passes, my knowledge is still deep, but I'll talk to you about how the brain functions for you to understand how our neural nets do today, to let you decide for yourself how the brain works, how neural nets work, how LLMs work. There's a lot of excitement because it does some amazing stuff, and that should tell you the future years are definitely in this space. But we don't know exactly what that path is. That I want to caution you. But this is the most exciting area because the fields of neuroscience, quantum computing, machine learning are eventually going to converge, as you will see. So without more, so let me start with this, the first slide. Now where do I point? Yeah, if you can see the next slide. This doesn't seem to work. Okay. Yeah, it's working, sorry. Yeah. So, the mid-80s to almost the end of 2000, almost, was all the era of what I call knowledge-based systems, logic. Somebody would put in the rules by hand, craft it, and the machine will get smarter and smarter, and eventually it will behave like a doctor, it will behave like everything, like the humans would not be needed. There was the 5th generation project of Japan, many of you may know this. None of this really happened. So there were projects at almost any university, which everybody was working in this space, and they did produce some remarkable systems. For example, some of you would know the IBM's Watson. I personally was fascinated by Maxima. I don't know how many of you know, because whenever I struggled with math, I would go to Maxima and ask it to solve that problem for me. So whether it's Bessel functions or anything, it sort of did expanded and simplified solutions for partial differential equations. So it was a lazy man's way of solving math problem. And this technology, ability to deal with symbols, reason, primarily through two mechanisms, forward chaining and backward chaining. Forward chaining was very much prevalent in Carnegie Mellon. They came up with languages like OXPy. MIT came up with Lisp as language for symbol processing. We used to call it my friends used to call it lots of imitating single parentheses. Because Lisp was famous for its first brackets. And then there were people in Europe mostly were into propositional logic like Kolmogorov and others who like to believe that logic, first order predicate calculus will solve everything, and that gave rise to the languages like Prolog. And for almost 2 decades, people thought this was AI, and it is not today. So all of us who did our PhDs in this era, and there were so many of them, we are pretty much obsolete because none of this really is out there. Now, around way back, 1959, Arthur Samuel was given, he was basically a mathematician at Bell Labs who came up with this idea of machine learning. And his idea was very simple. You put some data, put some model, and it will sort of crunch it and produce some answers, and effectively the machine will learn. That's what machine learning is, and linear regression and other forms of algorithms like Vapnik support vector machines, a little bit more mathematical. They were all in this field, but they were basically, it was like a statistical approach, you would say. It's really not intelligence, if you ask me. It's some data you throw in and you crunch some numbers, and eventually it comes up with the optimal model. So that was that era. And then the math behind, I want you to be patient and not sort of be irritated by these very simple equations. Machine learning is pretty much one equation. It is your some objective function, which is in this case is an error. Some model, equation 1 is a model, a very simple linear model. You run some positive, what we call convex function, because it will always converge, and you keep on crunching and minimize, and eventually you will get an answer. And this is how the gradient descent, that as you start off with unknowns, theta 0, theta 1, which you don't know what they are, x1, x2, you keep observing, y1 you observe, you keep doing it. If you go back to your school days when you fitted a line with a bunch of points, you minimize the error. It's a very simple elementary arithmetic, and that's all that's working in neural nets. We'll see that later. Now, interestingly, and I'll always go back to the brain actually functions like that. It does backward propagation. But let's wait for that slide to see why that is not that simple. But there is obviously a way when we make decisions. If you look at the brain, by the way, is a very complicated thing. There's a prefrontal cortex, there is amygdala, there is hippocampus, it's a zoo, 80 billion cells. So each part of them actually function differently. And here we have a very, very simplistic model which says we are going to regress through this and find a model. So that's the beginning of the machine learning. And not everything is a number. Sometimes it's binary, yes and no. So there we tweak this a little bit to this formula, and there, for people like what little bit into mathematics, will immediately realize that we get to something called log likelihood to force the answer to between 0 and 1. So it's very elementary stuff really. That's all there is to it in the world of ML. Either of these two equations are working, whether it's neural networks, whether it is GPT, whether it is reinforcement learning, whatever you say, machine learning is only classification. Don't forget this one statement. ML is classification, classification, classification. When I say 10 words, what's the next word? It is one word out of the dictionary, which is typically 2000 words that we use. So it's a classification. 2000 classes, you pick one class. GPT, same story. Decision trees, same story. So ML is classification. ML is not intelligence. Okay. Now, let's proceed forward. This is the first part of our discussion. And we come into some very elementary concepts. Obviously, you have to do correct fitting. Some of the words are like overfitting, underfitting. Means that if the model is too simplistic, it will do an underfit. You're trying to fit a circle with maybe just a straight line. Obviously, it's an underfit. Overfit, you get it. You're trying to force a solution. Now, we don't know these parameters. We don't know how many features we need. So how do we know what to be fit? And that discussion will come back to this in the world of GPT and LLM and see how this has become such a huge problem. So the one thing that now at this point we know that an elementary linear model with some kind of objective function that you want to minimize, you will run into one of these issues. Either it's an overfit or it's an underfit. What's an overfit? Well, you have a cubic function and you're trying to fit something which is an 8th order or 10th order. And you can do that because you have so much data. And the reverse is what? You have actually a parabola and you want to fit a straight line. The problem is you don't know. The machine doesn't know what that curve is. So, and this will become, I'm spending a minute here because you'll understand how this shapes in GPT. How that becomes a formidable problem in generative AI. Most of people are overwhelmed with generative AI, but that will come back to haunt you in the world of generative AI, this particular slide. Now, next is the last slide, which is mathematical. I promise you there's only one. That machine learning, I said, is all about classification. So not everything is continuous. There are groups of things. So way back, Claude Shannon, everyone would know him. He came up with the concept of entropy. And what that really means is that if there is order in the system, entropy will be low. It's a thermodynamic concept actually. It's kind of common sense. There's a lot of, like for example, if you don't know anything what's going to happen tomorrow, that means there is no probability of, you really can't say anything with any probability. That means there's a lot of entropy. It may rain, it may not rain, it may flood, it may not flood. So nothing is known. So there's total chaos. That concept is Shannon's entropy. It's typically used in something called a pre-log Q format. What the name is after the gentleman. Very simple concept to Hilbert library divergence. That you pick a model and you see that formula that you last line and you see how it matches with your reality. See the divergence. If the divergence is 0, that means you got it right. If the divergence is huge, that means your model is not good enough and you keep iterating. Why do you need this? This you need in those classes of problems where it's classification. So we end phase 1 of, I talked about the decision tree. We talked about regression. So you now need to come up with decision trees. Because that's another, we call decision trees also as artificial intelligence. At least we used to claim that once upon a time. Now, many of you would have played with XGBoost. It's a beautiful algorithm, very simple one, works great. If it is like 10 or 12 lines of parameters and very simple code, less than a page, it works wonderfully. And all it does, it does something like this. That if I'm tracking soccer games and I want to make sure that how do I structure them, the tree, do I group them by the teams when they play in the morning, or do I group them they play in the morning in the local, in the what they call home and away? How do we group them so that the information comes out very, very lucidly? And that's where we applied this entropy constant. The formulas that you saw there, you would like to come through these very elementary numbers and come up with an information gain, what they call, and see the one that has the highest information gain, you would want to organize your tree, your so-called tree that you see in Excel or anything in this format. So classical AI stops here. It comes into using regression, some model, and classification. So that's the end of 20 years of work. And obviously there's a lot more, but I think you get the sense. Then we move on to the world of neural nets, which will lead you to LLM. The neural nets, around 2000, when Hinton showed in the ImageNet conference the beauty of the CNN algorithm, and Hinton is actually credited to this gradient descent algorithm and the variations of that, and showed that the enormous capability of machines to recognize images. And it did a pretty good job. I mean, it could tell varieties of cats, varieties of dogs. And you will see later that while this was very nifty, it took enormous computing power to recognize. The amount of training that had to be done is mind-boggling. Now, but then that spawned a great interest in machine learning through neural nets. And today, for example, when you use Alexa or when you use Netflix, you will see all these neural nets making recommendations for you. So all of that is powered by the so-called deep learning. This is interesting because by the time in the late 70s, 80s, it was completely discredited initial and then kind of came back. And now, all of you know this neural net stuff. I captured it in one slide, very elementary stuff. What you see here on the sigma sign is that a bunch of inputs are coming in, and theta 0 to theta 1 are the weights. You multiply them and apply a function. And I'll come to why we have that function. That function is given below. It looks like a S-curve. There are three of them, sigmoid, hyperbolic, and rectified linear. So essentially, it's a threshold. So when you multiply all those summations and you pass to that function, it crosses the threshold, then you get the next value. If it doesn't cross the threshold, it doesn't. And it propagates. So you have this incredibly complicated network. And again, you do the gradient descent that I talked about earlier. And all of you are probably familiar with it. You don't even really need to know. Most of the software will do it for you. And you crunch backward, the weights will get adjusted. And that's a neural net. Now, does it converge? Nobody knows. Actually, in many cases, it doesn't. And why doesn't it converge? Because most of the time, the optimization for those of you who are mathematicians will immediately recognize it's a local maxima or local minima. So it's like saying I went to see the to the Mount Everest, but I landed up in Nainital and I didn't see any other peak higher than me. I can't say anything. So I concluded I'm at the highest peak when you are not. So that's the problem of this approach. And people try to solve it. We'll talk about it a little. But I want to spend a few minutes to understand this slide and the next slide. So what you see here as the sigmoid function is the activation function in the brain that once the threshold crosses, is fed into that function. If it crosses, only will it go to the next neuron. Otherwise, it is zero. And so, how do you know what the thetas are? You don't. You're just throwing some random numbers. And then you run experiments to see what it produces. It's completely supervised. Does it give the answers that you see? And that's exactly how LLM works, by the way. If it doesn't, you start changing the weights again. How do you change the weights? Well, you change the weights by the good old chain rule of differentiation. Remember that anything that I've talked in math here, you probably have done in grade 11. Probably earlier, I don't know, these days probably they teach it in class 2, I don't know, but given our competition. But this is the beginning of the math and pretty much all that is used. But here lies the problem. This is what the brain is. Now, I have a deep interest in the brain. So, I am not a physician. I know very little. So, with that caveat, I will tell you how the brain works. What you look at the nucleus, that's a neuron. And neurons are connected to the next neurons by axons. In the axon, you see there's a junction between the two neurons. What you see is the synapse, which is blown up there. The synapse is the Greek word which means a gap. it is not a continuous connection. So first thing you should understand in neural nets is, if a signal is 1, and if it crosses the threshold, the next neuron thinks it's 1, multiplied by the weight. The next one goes on, so the signal will travel entirely. The only way you can flip on and off is a sigmoid function, which simply says, is it going to or not? It's almost like a gate. It's not almost, it is a gate. That's not how the brain functions. The brain, the axon is the brain, the first part, the axon is an electrical signal. The electrical signal that comes to the synapse stops at the electrical signal because there is no connection. It cannot go forward. Understand the neural net and why LLM. All of this is coming from this. And if anybody is a neurologist here, will immediately jump and say, will be excited at this. What happens when the electrical signal comes at the synapse? The synaptic junction sends a chemical message. The chemical message is produced by the electrical signals by 1000 plus genes. There are 1000 plus genes right there in the signal. How do these electrical signals proceed? The electrical signals start by what is called an action potential because of the difference between sodium and potassium. Inside the neuron is potassium, outside it's sodium. These sodium-potassium potential differences start the electrical signal. So anything that you see, anything that you do, anything that you hear, anything does is a result of this action potential. The entire brain, this is the zuban of the brain, it only says action potential. Now the problem is, when the action potential goes to the synapse, how that signal will go out is not a single signal, it's a signal there on the right bottom there, all those fields. The very interesting thing about the brain is that the code that goes out is a sequence of signals. All of the signals are of the same height, amplitude, but the packing of the signals are different. The amount of information that is flowing out is enormously complex. There are people doing research on that, and I'll tell you how these researches are done. So our model of neuron is an extraordinarily simplistic model where it simply says a signal comes in, it goes out, but that's not what it is. When you hear a piece of music, first of all, your brain, we are making a neural network assumption that the neurons are uniform everywhere. That's not the case. The brain consists of distinct segments as what we know. The hippocampus, the hypothalamus, the amygdala, the prefrontal cortex. There are different parts of the brain. The brainstem is where all the chemical serotonin, dopamines are all generated from that. All of these things are used in the synapse to decide what kind of chemical signals are going. So you will immediately realize that this is a digital plus analog, whereas a neural network is completely digital. So neurologists will tell you what we have produced is more of a caricature, more of a toy, thinking that, oh, this is the brain. And neurologists don't even understand it, by the way. There are 80 billion neurons in the brain. 90% of the brain is water. 10% is actually used. Different parts of the brain are collaborating with different parts. So there is an objective function going on. We don't know. It's not that there's only one part of the brain that's doing the objective function. It's all over the place. We don't know which classes of neurons work together. The neurons differ. And now I think you will understand that the complexity and how this is different. There's a guy called Medanka Sur at MIT who does this, he's an electrical engineer. There's a lot of, I've been following him for a long time. He does work on understanding this, and the way he does that, he has instruments on photoluminescence and high-speed, studies on mice cells. So different parts of the brain lights up. There are videos out there, you can see it. So that's how he's sort of back calculating and saying which portions are working where, what are they doing, and is there a mathematical representation of that, right? So obviously this is way too complicated. And by the way, even before you go to the next step, there are people like Roger Penrose who believe that it's not only these neurons and synapses, but actually consciousness and thinking is part of a lower level quantum processes in the brain's tubule. microtubules. So this is like quantum computing, and I don't even understand that, there's no way to tell it whether it's right or wrong. So obviously one part is that the brain doesn't work the way, like neural nets. Even this description, according to Roger Penrose, he thinks that there is a at a quark level, something has happened, quantum entanglement. If you really have to read his book, I think the book came out in 1999, and it's a viewpoint where he draws concepts from Gödel's incompleteness theorem, quantum computing, quantum physics and brain, and there are people like Max Tegmark who don't believe in it. So I just don't know. I mean, I'm an engineer. This is way too far out. We are not even here. So now you are here. Okay. Now let's continue. So what did the computer scientists do? Well, they did some hacks. We're good at hacks. We said we'll have RNNs. We are going to take the state from one to the other. Basically, all the weights will carry on to the next state. And then they realized that this will be like you do with sequences. Because earlier neural nets, I showed all the input coming together. Now it will come as sequences. But then we soon realized it doesn't converge. Many of you know RNNs don't converge. They have the problem of vanishing gradients or zero gradients. And so this was given up. Then we did more hacks. We said, okay, there's a smart guy in Germany. He said, you will know, this works actually pretty well. LSTM, long short-term memory, that will have some gates. We introduced self-state and said we're going to tweak with the RNNs and force it to forget something and remember something and suit. And it worked for a limited, and for example, it's intuitive to you. If you say Ram met Sita, that makes sense. But Ram met Ram doesn't make sense, right? So I will force that through neural nets at a self state to force that whenever Ram meets Ram, no, that's not a valid sentence. So that kind of, basically common sense reasoning. But then also there's another branch of subject that popped up. We can't go into details. Reinforcement learning, a very, very important part of machine learning is reinforcement learning. RL is how I believe the brain works. Now there's different views of thought. Imagine a baby. A baby looks at 3 cats and recognizes the next one's a cat. A machine has to be trained with 1 billion images of cats, 1 million images of cats for it to recognize. So obviously something is very different happening. And the very different is happening is obvious also from the fact that the brain is very slow. A brain works at max 200 cycles per second. Mine probably works much less, but anyway. And a computer runs at gigahertz. Just imagine. But a baby is able to say a cat is a cat within, as soon as some neurons are developed in the head, very quickly. A computer, you keep feeding forever and it doesn't. Why is that? Because of the information content. The content that after the synapse what signal goes out is far more enriching information than what goes out of a neuron in a neural net. Remember, your brain is probably 1 kilo. 80 billion neurons in 1 kilo, which is less than 2% of your weight. Yet, it consumes 80% of what you eat, energy. Fascinating numbers. So, all the stuff that you eat, all the pizza, cokes that we eat is all going to fuel the brain, basically, right? And that's because the content of information that is created is of so high order. Whereas computers are basically doing very simplistic calculations again and again at a very high speed. That's the big difference. So now, we did some hacks and that worked, but then I'll move to the last part because we have time constraint, because this is the part where you probably are most interested in. All of that suddenly gave rise to the world of GPT. In 2017, this Google guy came up with a paper which caught my attention in 2017 itself because of its attention with the title. I thought this is a really weird title for a paper. So it grabbed my attention. So I read it a couple of times. And then I found that actually in 2014, Benjo and one of his students, Benjo from, I think, NYU, and Badano had produced an earlier paper, very similar in the context of translating languages, I think German, where they introduced this concept of, I'll come to that, but what did they try to solve? All of us know that This is the problem of machine learning language. You know, we went to the bank and learned of his bank empty account, after which we went to the river bank and cried. Now, a machine will be completely flummoxed, right? This is the problem of language. And that's why we talked about neural nets, that's why we talked about LSTMs. None of these really work. And people who worked on classical languages like Barbara Liskop and before that Chomsky, and both of them at MIT, they had a completely different approach to language. Suddenly the neural net guys came and said, LLM guys and came, we solved the problem. Did they? So let's look at that, because in these days, if you can't say GPT, you are not very smart, right? So we have to say GPT. So this is what GPT is. GPT introduced a few very interesting concepts. Simple concepts, elementary concepts. The concepts are, these are the last 3 or 4 slides. After that, you'll be a master of GPT and LLM. And you will see that this is now democratized. Everybody in the world can build these things. It's not just big companies with, all you need is a lot of server machines. You have to also, earlier we talked about neural nets being fed data, then we said one after the other. Here they introduced the concept that I will provide positional embedding. That means, where do these nodes out? Where do these words walk? So we went to the river bank. Every word we went to the river bank in a set of bits will also encode where that word exists in relation to the others. So it's actually a positional embedding. For the first time, they introduced that. They copied a concept from good old databases. Query times key must give value. For anybody who's coming from the database world and relational database will immediately recognize that query key value are nothing but database concepts. Query dot key must give me the value if I got them right. We'll see how that. Then they use the concept I'll talk about: attention, information prevention, and normalization and decoding. Very simple ideas. Let's see how this works or does not work. So first thing, the words that they come in now, they're coming serially. Words are not letters, words are embeddings. All of you know that. They're vector representations of some numbers. What we do, we create 3 arbitrary matrices, weights, neural nets, query, key, and value. What are the weightages of those? We don't know. Arbitrary. The idea is that if I do Q dot the input, whatever is coming in, it is a query representation of that same input. It's not the input, but the query representation. Bear with me for a second. I do that also for the key. Obviously, these are all wrong because your weights are wrong. You did the dot product, you got something, then you got Q and K. If you did a dot of those 2 matrix multiplications, you would get the value. Now, the value is also wrong, but hopefully they'll get trained. How will they get trained? So now, I have this embeddings coming in. I did the multiplication, and no, I don't do one representation Q, K, and V. I actually, V you don't create, V is generated. Q and K, I create 4, 8, multiple random matrices. Because we don't know what to start with, we create with multiple. So this is called multi-head attention. Why is it called attention? Query.key is the attention. How many of the K's and Q's do you do? 8 of them. Why did they do 8? Because that's what the Google guys started with. There's no reason. You did that, and then there's a technique for collapsing them to make them linear. Now you've got 8 results. Intuitively, it makes a lot of sense. If I tell a sentence, it's very hot today in Hyderabad, and if I ask the same question to 8 people or 10 people, their reactions will be different in their mind. There will be 10 interpretations, some of them similar, some of them not. So the language assessment of this sentence cannot be led by just one query and key, and that's essentially the idea, that we'll have multiple of those. And there are some very elementary matrix multiplications and coalescing of these that will result in one final output multi-head attention. And what that attention is actually very simple. It is you can clearly see, it's almost like a masking, I'll give an example after this, but also they did another nifty thing. They said after this query.key, they would add back the original positional embeddings back to it again, because there's no mathematics behind it. Why? They just felt like. because they would think they've lost the original positions of those words, what they meant. So while I have the intent capture, I'm again adding back the positional encodings, and then they do some normalizations, because this matrix has some are big numbers, some are small numbers. So you normalize by standard deviation and mean, and add a little bit below that 0.001, because sometimes if it goes to 0, it will blow up. So you will get a new matrix. So this is your multi-rate retention matrix, elementary math, right? You would get a matrix like this. And if you stare at this matrix, when you play the Game of Thrones, you will see the diagonal is very high. Why? Because it's most relevant to itself. After the crunching of this KQ, when you do all this matrix, this is like the Sobel matrix in image recognition, filter rather. Here, you have the words which are most relevant will pop up and a higher numbers, and that's your attention. So, for example, the word is pretty much one to itself because the word is most relevant to itself. So, when you say play the Game of Thrones, you will say the word the is not so important, so it's mostly 0. But when you say, some word like game, when you play the Game of Thrones, you will see correlation between game and thrones if your query and key were trained properly. So that idea is out there. And then what you do, the rest is very simple. After you do this stuff, what you do is, you take the K, Q and K from the decoding part of the story. Remember, this was the decoding part. We started off by saying the left part is decoding. Left part, that is decoding. Positional embedding, multi-rate attention, then again added a normalization. Now you got the Qs and Ks, which is fantastic. And then you take it to the other side and you're all done. You take it to the other side. Now you have to produce a next word. How do you do that? You simply mask attention matrix to zeros of the words that you haven't seen yet. Repeat the same process. So basically what you do after that, you will crunch to this number. Okay, I'll just stop here and take some questions, but essentially right at that step, after you got the K's and Q's and you did the dot product and produced a value and did the same old stuff again here, and eventually at the last layer, you are still doing a softmax, which is meaning picking a word, a statistical most relevant word, and so you now see that there goes your intelligence. It's at the end of it as a statistical machine, and it picks up a word. So you feed Wikipedia, it reads one after the other the words. After reading 10 words, it predicts the next 11th word. As long as it gets it right, it continues. If not, it goes back an iterations and keeps on changing. This, by the way, at this point is billions and billions of parameters with so many neural nets all over the place. And so eventually they'll get it right. But now, here's the thing, the last slide of my talk is, So GPT does not replicate human cognition. First thing we should understand. It differs from human cognitive process. It's just a statistical weight of one word with the other words. It's almost like saying, I am going to fit all the curves in the world with one parameterized equation. And anything that you throw at me, any equation, parabola, or whatever, circle, I'm going to take this one equation, which has all these weights, and it will give you the answer. So it is at best a weighted solution to that. Number two is that it will be prone to errors. What we love to say in the industry is hallucination. There is no hallucination, it's an error. It is statistical error coming out from picking a softmax. Remember, at this, then you will understand, GPT doesn't understand what an African elephant is. It knows Africa, it knows elephant. It doesn't understand African elephant because the elephant is the softmax of the previous state. It doesn't understand a Bengal tiger because it knows Bengal. It has seen many times Bengal and then tiger. So it will say Bengal tiger, but it has no notion what a Bengal tiger is. So, but it does jaw-dropping things. That you guys have seen it. And that's because, and nobody knows why. That's the beauty of it. Because statistical, basic statistics will tell you any overfitting will give you bad results. But what is very interesting in GPT is, as you fit more and more data, the results go up, then it goes down, then again goes up, and then again goes down. Why is this behavior happening? Nobody knows. So use GPT at your own peril, but I think you now know the opportunity is understanding the brain functions more, translating into neural networks which mimic the brain really, if you understand that, and add real computational processes, the convolutions that are happening inside the brain, the image processing that are happening, realistic modeling of those things are what will shape the future with the computing power that is arriving at our doorstep. So this journey will continue, and it will be, we just don't know which way it will go. But hopefully, with this I'll stop, and I know I'm over time, but hopefully this was interesting for you. If there are any questions, I can try to squeeze in a few. It is not a language model. It is a statistical grouping of words. And if it has seen many of such examples before, it is likely to parrot it. Think of it like your African grey parrot. It hears 10 words, it will say the 11th word, but it doesn't understand what it means. That is something you need to keep in mind. Thank you, Dr. Jaideep. That was quite a heady mix of mathematics, biology, quantum physics. Sir, Jaideep, you kept saying this is all elementary. That only served to remind me that I'm poor at all three subjects that you're touching upon. No, but thank you for this wonderful opening keynote. Well, now we'll head into the first panel discussion. The panel discussion will be on open source and AI. The way forward, again, open source needs no introduction as to why you are doing this panel discussion. But let me invite the panelists onto the stage. I'll start by inviting Mr. Nagarjun Maladi, Vice President, Tech Mahindra, a huge supporter of Sricha and open source software. Nagarjun Maladi, as we call him. Might I invite Rajendran Kaushik, Principal Architect, AWS. Thank you, Kaushik. Thank you for coming over here. Ranganathan, Ranga, I call him, co-founder, CTO at Everest Engineering. I would have been surprised if that reaction did not come. Ramesh Yoganathan, a person who needs no introduction, a huge advocate of open source, has been an influential figure in the startup ecosystem in Hyderabad, currently a professor at IIIT Hyderabad, and is involved with the CIE. Ramesh. Might I invite Amit Kumar? Amit Kumar is a senior director at Salesforce. Thank you, Amit, for coming over here. And to moderate the panel, might I invite Kaushik Katrapati, who heads data practice at DigiQuanta. DQ is one of the AIML partners for this conference. Kaushik brings in more than 18 years experience with working with data and other things. I have a small request to make to the panel, Kaushik and the others.
So we hear a lot of all these big companies pledging towards open source, like Meta, Facebook, everyone pledging towards open source models. But while all of these companies are pledging that they are open source, we have a basic problem, right? We don't understand, or like there is no clear definition of what is open source AI. What is your take on open source AI, and who can define it properly? Please.
Thanks, Kaushik. Good morning, everyone. First of all, I'm a firm believer of open source myself personally, and even when I started my career, I remember developing frameworks even before the microservices world. I was building something similar to that, and an open source entirely. So again, let's just take a simple stand of what open source is, right? It could simply mean a way of a developer or a contributor sharing their source of information or a code or whatnot with limited or no licensing arrangement or whatnot. So basically, anyone can flexibly or freely use that source of information. It could be a code, it could be data, it could be anything for their data. So if you really look at why open source is a popular topic now, if you look at why developers love it, our customers from Amazon or AWS, our customers love it.